Good evening and welcome once again to another superb evening of CPD with the Academy of Physical Medicine. I have a very special guest with me this evening. My guest started her career as a sports therapist. She's now a very experienced chartered physiotherapist with a lot of experience with the elite of British sport. She worked in Premiership football since 2003. She's been at 3 Olympics as part of the medical team in Athens, in Beijing and in London. And she has a number of clinics of her own across the west of the country. She has taught on MSc courses in sports therapy. She has an MSc herself in sports injuries, and she is the author of a very well-reviewed book, Sacroiliac Joint Dysfunction and Piriformis Syndrome. She's Paula Clayton. Paula, welcome to our studio. It's a delight to have you here.
Thank you very much.
I thought I'd start, and given the range of your experience with different levels of performance, and I'm sure it's not restricted just to elite athletes, that's not enough, but also with a whole range of conditions. Why a book on sacroiliac joints and piriformis?
Good question. I think because over the years of working with elite athletes and also having private practice, and then getting kind of asked to show and demonstrate why I do things and how I do things, and then over the periods of time I was invited by national governing bodies and into some Premiership teams they asked me to teach, and it always seemed to be the number one thing that they wanted me to teach was SIJ. So I think there's quite a lot of confusion around it. I think there's quite people either know one side of it, they know the treatment side, or they know the assessment side, but they haven't necessarily put together, all the puzzle pieces of how these things fit together, and it seems to elude people. So I tried to put in this book, the basics, but I tried to, I guess, clarify those puzzle pieces. I tried to get all of the assessments in there from, all of the latest evidence-based clusters of tests. Then went into building people's clinical reasonings with different types of kind of people understanding how the body and the different parts of the fascial, how that all that comes into play, and then also wanted to put into the book different things about different types of treatments. So different people had different things from their toolbox. But the reason I chose the SIJ was fundamentally because that seems to be the area of choice. And I've added in piriformis syndrome because it does have a little bit of a marriage. One
Yes.
can affect the other. So it kind of seemed to be the perfect thing to put in together.
So when you say you were asked to teach a lot about this, I mean, who were you asked by the patients or by fellow physio sports therapists? Yeah,
by fellow physios and soft tissue therapists. So I've gone into quite a few national governing body sports teams and a couple of Premiership teams, Man United and Liverpool. And I've gone in and I've taught their physios and their soft tissue therapists. And they always say, can you teach us something around the pelvis, and can you really focus on the SIJ?
Yeah, you mentioned a lot of different things a moment ago, and I have to say you don't sound much like a physiotherapist to me, because surely you should be just teaching exercises, not fascia and all this other stuff.
That's very, very...
Well, I mean, we all have our prejudices, I'm sure, not our prejudices, our focuses within our own disciplines. Certainly the SIJ for all osteopaths is a major part of training, and I can't speak for physios, but I suspect that a lot of us have perhaps forgotten why that is, or at least would like to be reminded what the current evidence supports. What is so significant about the SIJ? Why is it a problematic area?
Well, with the SIJ and with the pelvis in general, it's where most of the load goes through the body. It's how the load is transferred through the body, how the gravity is transferred through the body down into the legs. So it's something that can go wrong quite easily. And when there is a problem there, and you have this dysfunctional and these adaptations, if you've got an upslip, or you've got a rotation, or you've got a downslip, or you've got a posterior rotation, all of these things are read in the body in different ways. And I'm very much, you've kind of touched on the fact, surely I should be giving exercises. But with my background in soft tissue therapy, and one of my very first courses back in 1994 was a Rolfing course, which is sort of soft tissue course. So we get to look at the body as a whole. So I tend to look all over the body to see what could be wrong. And with the pelvis and with the SIJ in particular, it has lots of potential for things to be not quite right. If the slings running through the SIJ are not quite, things aren't working, muscles aren't firing correctly, and you don't have that forced closure with the soft tissues should be providing that sort of structural stability through the pelvis, then then other things go wrong. And then you've got to deal with those, and people will come in and go, oh, my knee hurts, or my shoulder hurts, or my neck hurts.
Yes.
And actually it's coming from the pelvis. So it's something, it's always my go-to. I always have a look there first to see if that could be influencing some of the things that people are talking about.
We've actually had quite an early question from an old colleague of mine, Robbie Passard, who's an osteopath now in Spain most of the time. To what extent does mainstream medicine still feel that the SIJ fuses? Do you know?
Well,
you work with...
It is, yeah, hi Robbie. I think the kind of the jury's out. There is, they say that there's 2 to 3 degrees of movement. They say there's 1 to 2 millimeters of translation, 2 to 3 degrees of, rotation. Does it move? It's a joint. It's got a synovial joint, it's a synovial area at the front, a fibrous area at the back. It's got a capsule around it, so it's a joint. So theoretically, it should move. As time goes on, does it fuse? I don't know. Don't know the answer to that question.
I was looking at a research paper into this where they had done some very careful analysis using, I can't remember the title of the name of the equipment, but it was designed purely to measure tiny movement. And I think the findings were that they found between 2.5 and 3.5 degrees of movement in the SIJ. And yet you can read another paper which says, well, actually we found that 1/2 of the SIJ fuses and the other half doesn't.
Yeah.
And I fail to understand how either half can move if 1/2 is fused.
I agree. And fundamentally, it's irrelevant, because if somebody's coming in with pain and dysfunction in that area, then whether the research says it's there or not, the person in front of you is presenting that. And it's that person's pain at that particular time of their life, on that particular day, in that particular part of their training, or that particular part of their injury. And it is, whether it moves or not is irrelevant to me, because if you're looking at pain in there, or if you're looking at dysfunction, there's lots of other things that you're looking at to see whether that's being affected. So yes, I can understand people saying, why are you checking to see if it's moving, and why isn't it moving? But for me, when I look at those kind of assessments, I'm not just looking at whether the joint's moving. I'm looking to see what the tissues are doing in those joints. I'm doing this but I'm looking to see how the tissues are responding around that joint, to see whether things are contracting, whether things are moving in that area. So.
Yeah, because it matters to us. I'm speaking as an osteopath, because of course all we do is click joints, as you know, and that'll annoy a lot of people. So we'll get letters about that.
True.
We'll get letters about that.
Yeah.
But if it doesn't move, there's no point trying to manipulate an SIJ. But I guess there must be a spectrum, those that do and those that don't.
Yeah, I mean, I guess if you're talking about manipulation, there's a big question there. Should it be manipped? Or should you...
Manipped, that physiotherapy expression. You're going to talk about mobes in a minute as well, aren't you? Yeah.
Adjusted, cavitated. There we go. That's an osteopathic. So whether it should be manipped or mobed is a question. But fundamentally, for me, I find I get the best results dealing with the soft tissues around that area, and then if it's very, very stubborn, then I'll look at doing an additional mob or manip. Yeah. But if it doesn't need it and I've got the results I want, then I don't do that.
Okay. A moment ago you said it's sort of the first area you'll look at when someone comes in for treatment. So does that apply across the spectrum of your patients, whether they're athletic or otherwise?
Yes.
Right.
It is something that I have, because again, I'm looking for those global changes. I'm looking to see if I'm getting somebody to do, if I'm looking at somebody's lumbar flexion, for example, why not then put my hands on there and do that at the same time? So it's something that I'm just looking at. It's not necessarily they've come in for that problem, but if they're coming for a shoulder problem and it's got some sort of insidious onset, they don't know what's happened, how it's come in, I'm thinking, could it be coming from somewhere else? My mind is always thinking, is it coming from somewhere else? So I start looking in other places. And I just kind of it's like an automatic thing, whether it's become a habit, but it certainly serves me well.
And when you come to do these assessments, and we can have a look at how you might do this later on, I can remember being taught 3 or 4 different tests for the SIJ when I was in training. I think I've counted in total 25 tests, which purport to give you an indication of whether there's sacroiliac dysfunction. What do you use?
So if I'm looking for a painful SIJ, there's a recent systematic review by Mangum Follier, and they talk about doing clusters. Most musculoskeletal assessments now discuss clusters, because most of them, if you look at tests individually, there's very few that have got high sensitivity and specificity, and most of them are, you know, at best, they're just kind of thrown up in the air and you're just kind of guessing, particularly a lot of the shoulder sort of assessments. So the kind of clusters that Mangan and Follier talk about, the one with the highest sensitivity is the one with the thigh thrust, and the one with the highest specificity is the compression, is the distraction test. Right. And what they say is that if you do these two tests and they become positive, then you don't necessarily have to take the patient or the client into another test just to irritate the joint. However, there's another systematic review around about the same time that talks about doing at least a cluster of 3 out of 4. So they say that if you get one of those is negative, then go into doing the kind of compression tests and then go into doing the sacral thrust test. So I think that most tests now are saying if you do a cluster of 3 of most tests and they come back positive, then, you know, then you've got a good idea. So if those come back painful, then you're looking at it is a painful SIJ. When it comes to dysfunction and movement tests, the ones with the highest sensitivity and specificity are things like the stalk test and the active straight leg raise.
Okay, and that's interesting, because of course, for many people, active straight leg raise will be a lumbar disc test.
Yes.
But it's not quite the same test for sacroiliacs, is it?
No.
Because it is an active test apart from anything else. So perhaps we can come on to that in a minute. Yeah. When you say a cluster of 3, I mean, are 3 out of any of those 25, or are there
no 3 out of 4?
Tests? Right.
Three out of the 4. So you'd first go the thigh thrust,
yep,
because that's got the highest sensitivity. So that this is highly recommended to do these two first. So the thigh thrust and the distraction test should always be done for a painful SIJ. Yeah. Then if they are positive, one systematic review will say then follow that up with either the sacral thrust or with the what was the other one I just said? The sacral thrust and the
compression.
Yeah, and the compression test. So one of those to just kind of confirm findings. If one of the first two is negative, then follow with a sacral thrust or a compression test, so that you've always got 3 before you can actually say, I think that this is a painful SIJ. But you've also got to include that. They're just tests. You've got to include that with all that subjective questioning and actually the presentation of the patient in front of you, and put those puzzle pieces together.
I read one paper. I say I read one paper, that makes me sound as though I read the paper. Of course, I scanned the paper. And I think it was from the early 2000s, where it said actually the most reliable test for a painful SIJ is when the patient takes his finger and says it hurts just there and points to it, which is, it's got a name, hasn't it?
Yeah.
Fortin's test or something.
Oh, okay.
Which is probably quite a useful one in its own right. Because actually, if someone points to the SIJ and says it's painful here, why would you do your tests?
Yeah, well, because you do need outcome measures. In order to be able to you need to be able to assess something. You need to do some sort of input, and then you need to assess again to see whether your input has been effective, whether the pain has reduced, or whether you've actually had a change in function. Okay. So you need an outcome measure. Okay. And same with the functional. Most people that present with a definite positive painful SIJ are likely to going to have to go down the medical route and potentially have some injection therapy. But those people with dysfunctional SIJs, really, it might be painful, but it's a different type of pain. The first ones are pain provocation tests. Yeah. The other ones, you're looking at dysfunction, but they come in and they're literally saying, I just want to stick my knuckles in here. They sometimes sit with their legs crossed. Yeah. When they stand up, they want to push their knees together in order to be able to stand up. And all of these kind of things come out in their discussions. They come out in the subjective, and you're asking questions like, is it painful when you walk? Because there's a recent piece of research that suggests that when you walk for more than 30 minutes, which is a sort of a dynamic and a dynamic load, that it's painful. Or if I stand for more than 30 minutes, there's 90% of people will say, that's painful, and that's a static load. And then people that are carrying shopping bags, they'll say that's painful, and that's like high 80s, the percentage of people saying, yes, that's very painful. So even with this kind of questioning, and it's kind of very qualitative, which doesn't necessarily fit in the world of some of the research, but it is a very qualitative kind of questioning, and it just starts to build a picture, and then your tests are just kind of confirming that.
Yes.
and then you're using them as outcome measures.
Okay. A couple of questions have come in while we've been talking. One was one which we just did, which is what are the 4 tests? Because whoever it is asked this question couldn't write them down quickly enough.
Oh.
So I should actually emphasise that, of course, this recording will go up onto the website, and there will be a text summary of what we say. So they will be listed there as well. But it was compression, distraction. The first two, of course, the thigh thrust and the distraction are the first 2.
Yes, thigh thrust and distraction are the definite first 2 that you do. And this is in the Mangan and Follier paper, 2009.
It's also in your book.
It's also in my book, thank you. So they're the first 2 that you do. And then you want to follow them up. Getting a cluster of 3, you want to either follow them up with a compression test or a sacral thrust test.
Right. And for the benefit of the lady or gentleman who's just sent that last question, it's the thigh thrust, not the high thrust. But we'll have a look at that later on. It's a relatively easy technique to demonstrate.
Oh yeah, they all, yeah.
And we've had, as most of our viewers will know, the questions are anonymous unless you tell us otherwise. And it was great of Robbie to say who he was earlier on, possibly because he and I know each other. I don't know Sarah, but Sarah in France has asked whether you find that some of these tests mobilise the joint anyway.
That's a good question. Hi, Sarah. That is a good question. And I think it's going to happen, particularly when you're looking at the pain provocation tests. You are mobilising the SIJ, absolutely. But what I'm trying to get across here with the way I do things is that is just an outcome measure. It doesn't solve the problem, in my opinion. It doesn't solve the problem to just manip that joint, which is what is basically happening when you do the assessment. It could be happening, I should say. Yeah. My opinion is you have to be dealing with all of the soft tissue structures around that joint. You have to address the quality and the quantity of movement around that joint, including the lower back and the hip. You have to be able to get full functional movement of all of the structures that should be providing that force closure to that joint before you can start to move somebody on. So just manipping it, in my opinion, isn't enough.
Okay. You talked about force closure there. There's force closure and form closure,
Yes.
aren't there? You might just want to explain what those are terms I only came across about 6 months ago, and I suspect those who are more recently out of college will have heard them. But
Sure.
Explain what they mean.
So force closure is where the sacrum fits into the pelvis, and it's like a block. It's like a block that fits in a perfect slot, and it is literally like a geometric perfect fit. It's a wedge, and it's a geometric fit, and it fits there. That's the force closure. The form closure is the structures that surround that joint that actually work on that joint to support the stability. So your slings, your glute max, your thoracolumbar fascia, all of the things passing through the pelvis and all the ligaments in the area, they offer your form closure, and they hold you. They should be supporting that joint. And it's when things go wrong and weaknesses and inhibitions happen that doesn't necessarily happen.
You mentioned a number of structures there. There are, of course, no muscles which directly affect the SIJ, are there? So what are, when it comes to, there's nothing that crosses the joint specifically. They act indirectly on the joint. So what are the muscles which we ought to be looking at or considering in terms of increasing that force on the joint? Yeah,
so with my fascial head on, they do. They do cross. So there's 3 main slings that cross across the joint. And act directly on your SIJ. You've got your posterior longitudinal sling, so that it basically consists of your rectus spinae.
We've got a picture of this, haven't we? Should we bring one of those up? Because I think, is that one there?
No, it's not. I sent them in the other thing. Yeah,
we haven't got a picture of that, so let's talk about it
sorry
anyway.
about that. But they're easy to find, and they are in the book.
Yeah.
So the posterior longitudinal sling, constitutes your erector spinae, thoracolumbar fascia, goes down through to your sacrotuberous ligament and then into your biceps femoris.
Right, on the same side or the opposite side?
Onto the contralateral opposite side. Sorry, so it comes across and goes. So these slings basically cross the body. Yeah. Then you've got your posterior oblique sling, and this is the one most people know of. So it goes latissimus dorsi, you've got your thoracolumbar fascia, and then into glute max, and that's a big player. Yeah. And then you've got your anterior oblique sling, and you've got you've got your obliques, internal, external. It goes across into your abdominal aponeurosis or linea alba, and then goes down into your inguinal ligament and into your adductors. So again, they all play a part. Those slings act very, very well to encourage form closure. Stability, strength, one-legged standing strength, being able to hop, skip, jump, run. Yeah. They offer that stability around that joint. When any of those points are not functioning correctly, then you can get a potential effect in your SIJ. And it's also the musculature and the kind of the fascial connections of the glute max, which then blends into the ilia, that blends into the thoracolumbar fascia, that blends into the latissimus dorsi, all as one thing. And again, like you've just suggested, if you look at, that's not on there. One of them's not on there, but that's okay. If you look at a fascial line that is the spiral line, you can see where there is one piece of fascia that can come from the back of your head, cross into your rhomboids, wrap around the front, go down into your ilia, and then it kind of wraps around your leg. And again, and then in the functional lines, they also become, they're also able to, if you look at the work by Stecco and the work by Myers, you can see that that's one piece of fascia. So they do influence each other through those chains.
Yeah, I think I mentioned to you earlier on, we had James Earls on one of our broadcasts a couple of months ago, I think, and he was talking a lot about this. And so that's the subject of one of our separate broadcasts. But where we didn't have the pictures now, we'll put those up in the text summary later, assuming James doesn't mind us using his images for that, so you can envisage those postural lines. Pain-provoking structures then. I mean, we're talking about, you said that the inevitable route for a painful SIJ is to go through injection therapy or surgery or whatever. Well, what is it that's provoking the pain? Why can't we fix it?
Because quite often it is it's an inflammatory, quite a big inflammatory response. And as we know, if things are incredibly we can work on it. We can work on the structures around it. But I'm loath to be bouncing on a joint or working through actually on the joint when something's so inflamed. Right. And just in my experience, people that have presented with that, and there's not very many people that present with true painful SIJ. You just have to look at the work of, what are their names now? I've forgotten their names. Oh, it's terrible. The lady that wrote the pelvis book. I can't remember her name. You just have to look at their work, and they are, it's very rare that you've got true painful SIJ. And I just know from experience of having that with athletes, they tend to go down that injection route. They tend to go and get prolotherapy. Also, people with hypermobility, that it's truly painful, they'll go and get some sort of prolotherapy. And yes, there is a, it's a bit wishy-washy as to whether it is massively effective, but some of them are definitely better, and some of them aren't necessarily better.
Yeah. Well, interesting you say that, because I've just been handed a question from Graham, who says that whenever he has patients with pain in the SI region, his findings are that 90% of these come from spinal referral, rather than the SI itself. And apart from inflammatory and rheumatological conditions, do you agree that the SI joint itself is rarely the pathology, which I think you've kindly just answered?
Yeah. Hi, Graham. So yeah, I think so. And that's why I tend to work on the structures around the joint to try and influence the joint, rather than the actual joint itself. And it is rare that I manip or mobe the joint, because the stuff that I do around it, hopefully, and then has an impact. Well, it does, in my opinion. And then you give them home advice, which is kind of stretching, self-mobilization, to kind of keep that moving, and then the strengthening stuff to kind of help with that form closure.
You're having quite an effect on our audience this evening.
Really?
Yeah.
I'm not. My bra's not showing again, is it?
we had an incident with the safety pin earlier on, which we're not going to go into now. But normally we don't get anyone tell us who they are, and yet they're all telling us who they are this evening.
Oh, well, they want to be said hello to.
This is from Maria, who is in the highly exotic spot of Uxbridge, who says, what do you work on to stabilise hypermobile SIJs?
Hi, Maria. A lot of the times when you look at somebody that's got a problem with their SIJ, there's always seems to be a glute max influence and strength in latissimus dorsi and glute max. So I quite often do a bridge assessment, and I look at seeing what kind of accessory movements, I don't mean accessory joint movements, I'm looking at a double leg bridge, and I'm looking to see whether they can actually control that concentrically, whether they can hold it isometrically, and whether they can then go into an eccentric lower, and whether they can control that without swimming in their pelvis.
Lower.
An eccentric
Yes,
back down
yeah,
to the bed.
yeah.
Yes, sorry.
Right.
And I'm looking to see whether they're wobbling all over the place, and quite often they are. And then just to confirm that and be really cruel, I then go and do a single leg bridge to just prove my point. No. I do a single leg bridge, and you will see an awful lot of lacking of control. So in order to add stability, it is literally tightening and strengthening. For me, what I always say is I like things to be long and strong, but not too long, normal length and strong. And so if those structures are weak that we're looking at, then we add strong strengthening in there. And it is, I peel it right back to the lowest kind of their ability level, and we build it up from there. And then, because it's very important, particularly with elite athletes, that stability is there, because I've worked with a lot of jumpers, high jumpers, triple jumpers, long jumpers, and so they're doing an awful lot of stuff with one leg, and they're pushing off massive amount of force through one leg. And so it's not uncommon even after one training session to come in and things just aren't quite right. And then we just do a little bit of jiggery pokery, wake things back up, tell them the kind of things that need to be put into their pre-warm-up kind of thing, and then off they go again. And that's where the kind of like performance therapy comes in.
There's a section in your book on jiggery pokery, isn't there?
Of course there is. Of course there is. I'm not sure it's entitled that, but that's what it is. Yeah. So so with regard to the answer to your question, Maria, it's about strengthening the structures that influence the SIJ. So having a look at those the posterior lines, and looking at the anterior lines, and looking at those oblique lines, all of those things, and think about the structures that are in those lines, and make sure that they're strong and long.
Okay. This question is from Leo, who's in London, but he says in brackets he's hoping to watch the next one of these in Spain. So good luck to you on that one.
Nice.
What exercises do you get people to do at home?
Right. Hi, Leo. So things like, I'll do a bridge assessment, and then I will get them to do that.
You're going to have to demonstrate the bridge assessment to us in a little while, I think,
yes,
aren't you?
Of course.
So we all know what you're talking about.
Yeah, I definitely do that, because it's a really nice way of looking to see whether they can actually activate the glutes. So I do a bridge assessment, and that will become one of the exercises. I always look at doing a front plank, side plank. I do and again, I do a thing, particularly with athletes. I would do a bunkie test, which again is described in the book, and it's been going on for a while, and it's been picked up now by strength and conditioning. So I think that there'll be more research into it, but it's not incredibly researched, but it's got a decent 12-year long program of research.
In simple terms, a bunkie test is like a plank, but with a foot supported on or with your feet between a platform. Is that right?
Yeah, you've got a 30 centimetre platform. Ideally, what you want is one that is like a little step, so you can put your foot through it.
Yes.
And you test the fascial lines. So you'll test the anterior power line, and all of the muscles in that line will be tested. You'll test the posterior power line, and all of the muscles will be tested. You'll test the lateral line, you'll test the medial line, and you'll test the posterior stabilizing line. And basically, with an elite athlete, they should be able to hold all of those positions for about 40 seconds. Before that happens, if there's any burning, pain, any kind of sensation, cramping, that's when you stop the test. What you'll normally see is one side will be 40 seconds easily, and you just stop the test, and the other side will be like 5 or 8 seconds or 10 seconds. You'll find out where the burning is, and it's not always the area that's a problem. And again, it's about the fascial lines, and they do work. So if you're looking at the bunkie test, and you're looking at for example, the posterior power line, you're also testing this superficial back line here. Right. And all of the structures in there, okay? And if you're testing the anterior, you'll be testing all of the anterior structures. So if you know your fascial lines, or you want to read up on them, it kind of tests those structures. It doesn't say that it does, but it does.
Okay. You've described those tests, and we've all got in our mind now an image of what those tests entail. And they might be great for elite athletes, and they'll be great for our elite cyclist who's come in to be your model for this evening. But my 90-year-old lady patients aren't going to be very happy doing bunkie tests.
No, that's true. But I do use this on normal people too. I say normal people, like people that aren't athletes.
People normal. Like us.
Yeah, normal people. So I do use this on normal people as well. And the beauty of it is it can then be used as part of their strength program. It's quite easy to do. They could do it on something at home. So if they've got a line that's particularly weak and they're only be able to hold it for 5 seconds, you might then say, right, I just want you to do 6 3-second holds and start to build it up.
Yeah.
So you can actually give it as part of their strengthening thing. And the other question they were asking about strength is, so yes, I use side planks, I use front planks, because I'm trying to switch on the structures that are usually inhibited by dysfunction or pain.
You've avoided the term core stability so far. Is that deliberate or?
Not really, because most of the things that you do when you are using a whole body like a plank or using a side plank or using a bridge even, you are actually engaging the core in some way, but it's not a specific core stability stuff. It kind of just happens. Yeah. So it's not like, I'm not particularly looking at like the traditional core stability exercises.
No, okay. I mean, and I noticed that in your book you refer to A.L. Lederman on at least one occasion, I think, and his belief in functional exercises rather than trying to switch on this muscle half a second earlier than it was, or a millisecond earlier than it was before, which is quite nice to hear. But it's a quite,
it's, you know, those examples of testing, you know, when you're doing a glute test, for example, to see what the firing pattern, they're a great outcome measure.
Yes.
So again, you just keep them in the back of your mind. They're not the be all and end all. They just guide you, but they're a great outcome measure. And the actual patient, client, athlete can actually buy in because they can see the difference and they can see that that is now changed and they're working on that.
Yeah. Okay. You'll like this. There's a comment from Jace in Norwich, which I've just received. He says that he wasn't aware until now that we couldn't see their details unless they tell us. So I don't know if that means he's already asked a question. But he says Paula's really good and he's enjoying the broadcast. So
thank
well
you,
done
Jace.
so far.
Thank you.
Now here's one. This person hasn't identified themselves unless it's Jace. In practice, do you see a difference between male and female SIJ pain presentation, or is there any evidence of presentation ratio difference between the two? Gender bias? Not
really. I wouldn't say I see a difference. I would say that it is pretty much a 50-50 thing. Right. I know that females, particularly if they've had babies, or they, you know, because of the, you know, the menstrual cycle, and at that particular time of the month, how, you know, there are softening of the ligaments, and you know, there was an interesting paper that suggested that people that are pregnant, ladies that are pregnant, that they get really tight hamstrings, and that there is evidence to suggest that that's trying to force or put a force through your sacrotuberous ligament to try and offer some stability around your SIJ. So I think that quite often when ladies come in that do have this problem, they've quite often had children and it's been an ongoing situation. Mm-hmm. But equally, I see elite athletes and normal athletes that are having the same issues, but they, you know, a lot of it comes to do with too much load. They've increased their load too much and their body can't absorb those forces. And again, if you're not hydrated correctly, your body cannot absorb the forces that it should be able to do because
Go on, sorry.
I was just saying, because the fascia and the thixotropic nature of the fascia and the kind of sliding that you need to be happening in there, that can be affected. So therefore the load then can't be dissipated and used correctly. And you have, you know, so it could be just somebody who's training, and they're just running for fun, or they're just running because they're trying to, you know, enter a charity competition, or it could be a massive race for them, or it could be biking, whatever. But fundamentally, if their load isn't correct, it can then affect, and you can become inhibited because you're overloaded. Yeah. So it can happen to anybody.
So how do you measure their hydration then? Because that seems like that's a bit of a finger in the wind thing, isn't it?
Yeah, well, I have a discussion with them about hydration. You can feel whether they're hydrated or not in their tissues. You do have an element of, when you're working through tissues, there can be some bubbling and cracking. It's a bit like scrumpling up a Tesco's carrier bag.
That's an extreme end of the spectrum though, isn't it?
No, not at all. When you're working through soft tissue structures, there definitely is a palpable feel. And also if you use lotion, they drink it really, really quickly. But I'm obviously always having a conversation with them about their colour of their urine, you know, how they hydrate, and the way to get to the bottom of that is to find out what colour
Do you recommend a quantity of water per day? I mean, it used to be guidelines, used to be something like 2 litres a day or something, didn't it? Which would make you pretty boggy by the end of the day if you weren't an elite athlete.
You say that, but I drink about 3 litres of water a day, and I think that I've just found my happy medium. And I think that I do, again, I speak to people about their urine, and I try to encourage them to keep it straw-like.
Yeah.
And if it isn't, then drink more. And some people will come back and say it worked well at 2 litres or 1.5 litres, and other people will say I'm drinking 2.5 to 3 litres. So it's very individual. You know, we are physiological beings, so it is very, very individual. But I try to get people to hydrate quite well before I see them, because it makes a difference in the response of the
And
tissues.
do you drink your water neat, or do you dilute it with something a bit
Neat.
more interesting?
Just neat, I'm afraid. On the rocks.
A question from an anonymous viewer. How do you ensure that a normal person, in inverted commas, i.e. not an athlete, can do a plank properly?
Good point. I'll ask them if they can do a plank, and if they say yes I can, I'll say can you show me?
Yeah.
And if they say I'm not sure, then I'll demonstrate it. And if they are not able to do it a full plank, then I'll just get them to do it on their knees. Most people can do a plank from their knees, even the.
And do you recommend Pilates to people?
Definitely, all the time.
Yeah. What about yoga?
Yeah, not so much. Only because I've had a lot of people in with injuries from yoga because of the forced flexion, double leg work, particularly with people with lower back problems. They do struggle with things that are done with double legs, and then trying to pull your head between your knees.
And do you think this is this is probably a simple question to answer. Is this a problem with yoga, or is this a problem with yoga instructors who don't really pay attention to their individual patients or students?
Yeah.
Because I don't see that in my own clinic. I don't see it with Pilates students, because there seems to be less scope for people being pushed into difficult positions.
Yeah, that's a really good question. I think that whether the yoga teacher is good or bad, or not so good, it's not really fair to blame them either, because you have a responsibility to know that you should not be trying to compete with yourself and trying to push yourself into really awkward positions when it hurts. And people tend to think that they need to do that because they're looking at the person next to them and they're trying to copy them. Yes. And I think people need to understand that it's not about that. It's about you as an individual, and it's about, again, we go back to function. Who needs to put their head between their knees? In functional, who needs to do that? It's not a necessity. So with Pilates, it's much more about staying long and strong, which is what I'm a big advocate of. And I don't think yoga is a problem if you are skilled enough at it, and you do have an excellent teacher, and they are. It's a difficult one. I've treated a bunch of yoga teachers. Because they get injured with their backs because of these positions and these. I think the strength yoga, the Ashtanga, I think it's called, when they're holding poses, I don't think that's an issue. I think it's the flexibility that sometimes takes people a little bit beyond their capabilities.
I've always thought it's harder for an instructor to injure their clients in a Pilates than it is in yoga, because Pilates doesn't emphasise those huge flexions and so on.
Yeah.
But we did our most recent guest was Leon Chato, and he does recommend yoga for his patients, but he was very specific. He's not too sure about the more energetic and strange forms of yoga. Well, yeah, I was going to come on to that, because he was talking to us about respiratory breathing problems, and he did identify breathing problems as being part of the issue with sacroiliac pain as well. I mean, is that something that you see? Yeah,
definitely. I think that if you're again, putting my fascial head on, I'm not sure if everybody out there is aware, but out of the diaphragm comes these little fascial fingers that insert into the psoas. And that's where, it has a massive effect on stability. Yes. And I just know from, I used to do, when I was working, when I was doing some placements and things like that, working on falls patients, and, how we could influence their stability just standing and walking by giving them diaphragmatic breathing exercises. And people seem to have lost the ability to be able to breathe with their diaphragm, and they tend to be much more chest breathers.
Why is that?
I think that it's sitting in the way we sit at school and hunched over. It's easier to breathe with your chest. It's very hard to diaphragmatic breathe in this position. So posturally, it's difficult. I just think that you look at a bunch of toddlers running around, they're all, ooh, the bellies are all going, but it's all coming up here. So, it could be pollution, asthma, there's all sorts of, different things that it could be. Stress.
There's a bit of fashion involved in it too, isn't there? Because what we in the services, in my time in the services, would have called the muscle bosuns, like to have a big chest and a flat stomach, so they hold the stomach in and they won't breathe through their abdomen or through their diaphragm. They'll do it all through the chest because it looks much more impressive in the mirror.
That's a good point. But also,
so do you advise your athletes about breathing properly?
Of course, yeah.
Do they take your advice?
Yes, they do, because I test them afterwards. Like, show me a diaphragmatic breath. So no, it is really, really valuable, and it's pretty impressive if you can do a psoas strength test and not do any diaphragmatic breathing, test the strength of the psoas, get them to do diaphragmatic breathing, and all of a sudden, boom, there's much more strength in the psoas, so it wakes that baby up.
Yeah.
Okay. So it's a really, really nice thing. It's an easy thing for somebody to do as well. It's an easy part of their just their normal everyday training.
One of the things that I remember Leon Chato saying, which is perhaps less obvious, it's certainly a lot less obvious to me, is that we were talking about breathing pattern disorders, so hyperventilation, overbreathing. And he was saying that overbreathing, which is common in the later stage of the menstrual cycle, it's more common in women than it is in men, but it switches off transversus abdominis, both in postural and phasic operation, which has a big effect on stabilisation of the SIJ. So rehabilitation of breathing is just as important, the manner of breathing through the diaphragm, but also the way people can be educated to stop overbreathing is very important, which I have to say, I really enjoyed, not what you've just said, but that as well, because it does make this feel a lot more holistic than just saying your sacroiliac's painful, let's whack it and see what happens.
There's so many things that affect your body physiologically that you really need to, some of them are very, very simple to change. They're very simple, and people will come back and just say, even just with the breathing exercises, I've just got more clarity. The brain doesn't feel as foggy. They're drinking a little bit more. They feel more stable around the base. And so I think there's a lot to be said for that. And again, talking about those fascial attachments, and then obviously if your diaphragm is attached to it goes into your psoas, and then it affects the linea alba, there you're going to go. You're going to have abdominal aponeurosis, you're going to have your pelvic floor, you're going to have your transabs, all of those things are massively, there is a cylinder that goes literally from your diaphragm to your pelvic floor, and they're all connected all the way down, and if your breathing is incorrect, all of those things can be inhibited. So absolutely, totally agree with him.
Yeah, I've got to apologise to the audience now.
Uh-oh.
I've just been bollocked. This particular questioner or viewer...
I didn't answer it.
No. This particular viewer, who remained anonymous, says he's had several patients injured from Pilates as well. So I do apologise that I've never seen anyone injured from Pilates. Gym classes do Pilates, but have too many in the class, which is often a problem with any class, isn't it? And it's not yoga versus Pilates, it's entirely an instructor. I do take that point. Yeah. If there isn't good supervision, then all of these things can go wrong. Oh dear, what's this one? This is another question, different person. Are the fibrocytic nodules around the SI joint significant?
I don't think so.
Good.
No, you're talking about those little jelly bits that, kind of sit there. I don't think so. They don't seem to. I think the only time that you have a problem in that area is if it's very, very close to the cluneal nerve, and it can irritate the nerve there.
Right.
If they become kind of inflamed or a little bit too fatty or whatever, then the cluneal nerve that passes just slightly lateral to those can be
okay, but we're getting back to the exotics now, because this question's come from Mark, who says it's cold in Oslo, which is...
Hi, Mark.
Yeah, I don't think that's going to come as any surprise to anybody.
No.
At this time of year, it's cold in Oslo.
You can go skiing soon.
Do you do a lot of hands-on work fascially around SIJs?
Yes.
Okay, good. Well, that's a simple answer.
Yes, I do. I do. I'll use some sort of myofascial techniques that go literally from the shoulders, because I try to engage the. Let's get this picture up. So the picture on the left there, I try to. It attaches from the gallia aponeurotica, which is basically a nice name for just above your eyebrows. Goes all the way over the back of your head, comes all the way down the body and into your plantar fascia, and this is one piece of fascia. So I try to work. I work from the shoulders down, because it's very hard to massage somebody's eyebrows. So I work from the shoulders down, go down into the SIJ to try and give some, because quite often what you see is most people posturally are more like this.
Yes.
So the fascia up
So
the back
that's
of the
what
body.
upper cross pattern with
Yeah,
protracted shoulders
upper cross syndrome, and that kind of thing. But fundamentally, when you're standing in this position, everything up that back that we're showing there is too long, and everything down the front is too short. So what we need to do is bring that back down and kind of shorten that thing so that we can not only put some slack. It sounds weird to say shorten then put slack in, but we're basically bringing the fascia back downwards, but putting and giving a little bit of space around the SIJ, but we're also straightening, hopefully trying to straighten the body up. And sometimes you have to work at the front in order to do that as well. Yeah. So fascially I work around there. I use my elbow and I glide down through the ligaments. I also use this lovely little baby tool here over the ligaments, so I get the beak end here and I work through there and I kind of wiggle through there.
Hold it. This is a tool which you've stolen from London Underground, which is used for breaking the windows in an emergency.
It's exactly
isn't it?
what it's for.
Yeah, exactly. So it's curved. It's got a concave groove down one side, the opposite on the other, and it's got that glass breaking piece on the end there. So why is that a useful thing?
Well, when you're working with fascia, as most people will know, you're trying to influence those thixotropic properties by putting, and you just have to look at any work from Schleep and Stecco and all of those lovely people that I absolutely adore. You know, basically they're saying that when you start working, putting your hands on fascia and putting pressure through that, whether it's a tool or your hands, you are then changing the hierarchy. Basically, if it's too thick and sticky, by putting pressure on that, it changes the polymerization and the depolymerization of the fascia. I'm sorry, they're really big words. I don't know how to say it any differently.
That's
and
okay.
These GAGs or glycosaminoglycans, they are hydrophilic, so they attract water. By putting pressure through the fascia, it attracts water.
Right.
And so therefore you improve sliding.
Yep.
So whether it's your thumb, your elbow, or this tool here, the reason a lot of people will use this globally and everywhere, and it's great for a pre-comp preparation because it makes people feel light. But where I like to use this the best is around joints, so you can get in around fingers and around knees and around the SIJ and across the sacrum. Okay. Very hard to get your fingers in there and do that. Excuse me. So by putting that through there, it increases that, theoretically increases that hydrophilic.
That's the next thing, isn't it? Is it the evidence that this is actually working, or?
Well, if you look at the research that, particularly people like Graston, they're a massive company. They have a beautiful array of tools that look like something a surgeon would have. You know, you kind of roll these things out, and their research is pretty good. And we talk about research, but for me, again, I'm guided by research, but it's not my be all and end all. It depends on what person is in front of me and what they're like at that particular time. And I can only say it makes a difference in the way people can move and the way they feel. And it seems to hold quite well. Yeah.
What's this tool called again?
This one's called a connective. There are other tools out there, but this is I know that sounds
other tools are available,
but there are. But this is my favourite.
Right.
This has been produced by a chiropractor, and it's got a beautiful edge on it, and it just feels really good in my hand now. So I use it like this, and it's easy to flip round, and it kind of fits nicely in your fingers. And because when you're using it with an emollient, it gets quite slippy because it's stainless steel. Right. When this tool first came out, I got really annoyed by it, because one of my skills was to pick out fascial stickiness because I had such great palpation. And then this baby came along and just, all you have to do is rub it along and it goes, and I'm like, so anyway, but I love it. It does work really well.
And is that there will be some people who are resistant to tools like that. Is that a tool that you've got to be trained to use? I mean, is there a chiropractic course to teach you how to use the tool? I
don't think you need to have in my opinion, there are courses out there that will, it's really hard to answer this one now. There are courses out there that will teach you to use this tool, which I went on, by the way, and it was very cheap, and I did it, I think, with Leicester Tigers, and it was, and I think the beauty of the course is if you're very sceptical, like I was like, yeah, whatever, and then I went there and I used it, I was like, wow, and I was really impressed by it and how it felt on my own body that I had to have one. And I was very lucky because British Athletics bought it for me. They probably
expensive?
want it back now. That one is about £350.
£350?
Yeah.
Good Lord.
But there are other tools out there for about 100.
Right.
So that's what when I said there are other tools out there, this one seems to be expensive. But for me, I use it a lot. And it's particularly good when somebody has had surgery around scar tissue and around portals. Yeah. Really good to pick through them.
Okay. Jace from Norwich is back on the chat line. First of all, the question he asks here, and I think it really means, we all got a vague idea of what viscosity means. What does viscosity mean in the sense that you used it earlier on? Right,
so we're talking about, the way I like to talk about thixotropy and viscosity is when something isn't quite right, it does feel like a Tesco's carrier bag. It does have that kind of crispy, crunchy lack of kind of movement in it.
You want it to feel like a Waitrose carrier bag?
I want it to feel like Tesco's, good point. I want it to feel like a piece of cling film with oil on it. Yeah. That's what I want it to feel like. Yeah. I want it to be gliding and beautiful and, kind of, and there is, when you start working on somebody, when you're doing fascial techniques particularly, it's very stingy and very burny. It feels like, your big brother's doing a bit of, what they call Chinese burns on you.
Other burns are available, no offence to any Chinese viewers.
But that's what it feels like. And when the tissue changes, you don't have as much resistance behind your thumbs. Right. So when it's not moving, you can be stuck in a position for a long period of time. You have to wait for the tissue in front of there to go before you glide. And then the next journey through that tissue, it does glide beautifully. So you can feel the changes. Yeah. I think you can, but again, that could be.
Yeah, I'm sure there's a degree of experience that comes into this, and I should imagine that. Well, in fact, one of our, I think an osteopath, Claire in Edinburgh, has chatted in to say, "Don't worry, that we do understand the long words, so it's okay to use
it." Thanks, Claire.
and I'm pretty sure that the tissue palpation skills of most osteopaths, so certainly if they've been in practice for a little while, will be quite good.
Definitely.
And again, I can't speak for physios, and there'll be those in our audience, but I'm pretty sure they'll have pretty good palpation skills as well. You're not looking convinced. I said, you can be rude about physios. I can't be rude about physios.
I think it's a mixed bunch. I think the beauty of osteopathy is that it is your 3, 4, 5 year degrees are fully musculoskeletal, and physiotherapy is only a third of their whole qualification. The first bit is, you're doing respiratory and you're doing neuro, and then there's only a third in MSK. Yeah. So usually it's post-grad. And once you're out there in the big wide world, if you're interested, your hands-on techniques will become much better. But it's not something that they particularly work on during your degree course.
Yeah. Jace from Norwich, his other point, he's very glad that you said what you did about yoga because, and again, no prejudice against yoga particularly, but some instructors can go overboard on the whole stretching business. What he has asked here is, are you more in favour of strengthening or stretching, or is it a literal balance?
I think if it's short, stretch it. I think if it's weak, strengthen it. I think that if it's, for me, stretches should be held for 60 to 90 seconds to at least get a chance of having a fascial involvement. Otherwise, you're missing out on you may as well just hold it and try and do as for long as you can to try and get that fascia to kick in. Because if it's a hamstrings around your knee, you'll get that involvement of the capsule and the joint fascia. And without holding it for that length of time, you're kind of missing a big thing. Yeah. So if it's short, stretch it first, then strengthen it. Strengthen a tissue that's in the right place.
We've been keeping our model waiting for quite a long time so far, haven't we? Perhaps it's time we got off our backsides and did some proper breathing. Would you like to start first of all with your simple approach to assessing an SIJ? Sure. Putting into perspective what you said earlier on. Charlie, would you like to come and join us over here?
So maybe what I'll do over here is I'll demonstrate obviously the functional SIJ tests, or the first couple, and then maybe we can go over there and I'll show you.
Yeah, and one of our viewers has asked if we can see that tool in action as well, because they think it looks like a hoof pick, and Charlie hasn't revealed the fact that he's got hoofs.
It does look like a hoof pick.
Anyway, so
Charlie's got his shoes off. The only reason I would leave shoes on during an assessment like this if they're wearing orthotics, because otherwise you can get kind of a false negative. So you want the person to be fairly relaxed, and ideally their shirt will be off. Okay, if not, tuck it into the bra strap there. Then you want to be able to expose the PSISs. Okay, so the first thing I'm going to look at So the two the functional tests we talked about, they were the stalk test and also the active straight leg raise. But as we're standing here, I'll also show you the flexion test. Okay, so the stalk test starts with your thumb. If let's say we're doing the right side, so you'd have your right thumb on the PSIS, and then you'd have your left thumb on the S2. Now you can use this for two ways. You can either test the side that we're standing on, which is the right side, and I could get him to lift his left leg, and that would show me whether the load transfer was good. And you should see no movement at all if the load transfer is good. Then you can also test the movement of this joint, and that's by lifting the right leg. Okay, so
when you say the movement of what
of
compared
the
to what?
SIJ.
Okay.
So what you should see is in a normal movement, you should see the thumb drop down, okay, to show that the ilium is moving independent of the sacrum. Okay, so your thumbs are placed in this position, and you also have to assume that because again you'll get two things here. If the person can't load onto the left leg, they'll wobble all over the place, and that's information as well. So Charlie, all I want you to do is lift your right knee just up in line with your belly button, nice and slowly. Thank you. So so it's quite hard for him to actually do that just without looking at what the SIJ is. He had to really kind of load transfer to be able to do that and come back down. Okay, let's give you, so what you can do, so if I just give you this to just fingertip touch, just to give you a little bit of balance, and let's see if that changes this. So now lift your right leg again for me. So it's a little bit easier for him to do, okay? And we should see this move down, okay? Which it didn't necessarily do, and come back down. Was that clear? Yeah? So yes. I'll just repeat that. If you're chesting the right-hand side and the leg is moving, you're looking for movement.
And the SIJ is moving.
And if you're yes, and the SIJ is moving. Yeah. And if you're testing the right side for stability and load transfer, you would move the left leg, and there should be no movement of the SIJ. It should be solid. Okay. The second thing that you can do here is called the flexion test. There's not great sensitivity and specificity in this test, and it also can give you a false positive because you could have a tight hamstring that could pull your pelvis down. So just take your feet hip width apart for me, please, Charlie. Thank you. Okay, and all I want you to do now is I want you to bend forward as far as you can go. And what you're looking for here is an even distribution of these thumbs, and come back up. If one side was really stuck, what you would see is one side would go up, yeah? And then you would take that. But you can see why, if tissues are tight, that might affect that, that reading, okay? The other test, should we go over here onto the...
Yeah, let's do that.
Sure.
Let's move on to the treatment technique.
As you know, with a straight leg raise, a lot of people will do this for like a neurodynamic testing, but we're not looking at that. We're not going to add in dorsiflexion, and we're not going to add in cervical flexion. We're just going to look and see if Charlie can lift his leg up 8 inches off the bed. So can you just put your hands by your side for me, please, Charlie? Just lift your left leg up, and then lower, and lift your right leg up, and lower. What you're looking for here is, does one leg feel heavier than the other? If your patient or client says, yes, one leg feels heavier than the other, then there's a few things that you can do to just see if compression is a problem. Is it lacking in compression, or does it have too much compression? So if it's lacking in compression, the straight leg raise will be better when I add to these movements. If it's got too much compression, the straight leg raise will be worse. Okay. Most people with an SIJ problem will say, my left leg, they quite often say, it feels like I'm dragging my leg around. So when you do this test, they say it feels at least 50% heavier than the other side. If you add compression to both ilia, pushing them in together, and the straight leg raise is easier. So let's say you lift your left leg.
Your hands look as though they're over the trochanters at the moment.
Yeah,
just
okay,
above.
sorry.
I'm sorry, that was a question, sorry.
Yeah, no, I would be there for that. Yeah, so I'm higher up, they're over the ilia, okay, and I'm pushing in. If the straight leg raise now becomes easier, there's a very good possibility that transabs is a problem. It's not functioning correctly, it's not giving the compression that it needs. So I'm acting as transabs. If my hands are over the greater trochanters and I squeeze in and his straight leg raise is easier, then we're talking about pelvic floor. So he says, oh yeah, it's much easier. Then we'd be looking at pelvic floor exercises. Right. Okay? And then equally, if I give if I do a kind of a distraction, so I'm putting a compression in the back of the into the SIJs itself, and he says that's much, much easier, then you're looking at multifidus, okay? Right. So if any of those ones help with the straight leg raise, then what's happening is those are the kind of things you would be looking at to add into the programme to start strengthening up those issues so that when you came back, that test would be different.
And how easy is it to target those specific muscles? I noted that in Leon Chato's book on pelvic pain, chronic pelvic pain, he said that transabs you've mentioned already, he said that when you rehab them, it's got to be targeted, it's got to be very specific, and it's got to be very progressive. But how do you ensure that that happens with your patients?
So again, when we were talking about breathing, so you could just do some diaphragmatic breathing. Again, that should influence transabs. Yeah. You could do the Pilates type dropouts, knee dropouts, so bend both knees. You'd have to be able to teach them to engage transabs first, and then they would slowly drop out or move the legs. So again, Pilates type exercises. Yes. And again, if you're using any kind of, even just a front plank, those things will switch on because it's a global right. stability in order to keep your body upright. So again, with with multifidus, you can use those kind of EMG kind of things, the little bladders that you can put under your back, and again, you can do a posterior plank, up onto your elbows, and there's a multitude of different kind of exercises you can do to engage them, which I'm sure everybody can find on YouTube and things. Yeah. And again, with pelvic floor, it's a case of drawing up and stopping the flow of urine, and again, that can be activated by diaphragmatic breathing as well. Okay. So combining a bunch of different things together. But for me, it's also, once you get everything else working, if we assume that glutes aren't working correctly, once you start getting those glutes to switch back on and you start getting the strength back in there, then quite often some of the other muscles kind of fall into play.
Okay. We did have our question earlier on about how do you use this, the hoof pick on your patient here.
If you pop onto your tummy for me, please, Charlie. So you can obviously use a pillow underneath the tummy, but we don't need to in this instance. So for example, you would have an emollient, okay? And I would, after I've worked in the tissue, because I always use sort of dry fascial techniques first before I add any kind of lubricant. But with this, you would want lubricant because otherwise you get like petechial hemorrhaging while you're, So basically, I would then come down into the SIJ. I would work globally here using this tool. I could put the patient on all fours and do a cat and camel and really kind of get through these tissues first. And then using my hoof pick, my picking part, I can get right down and work across the ligaments around the sacral crest and around the spine of the sacrum and start working down through those ligaments. And I could use the flat edge or I could use the beak edge to do that. And it all
how long would you spend doing that?
I usually stop when the skin starts to turn slightly pink because, again, I don't want to cause any kind of bruising. And again, I do fairly because I've already done some of the work into this area, I don't have to spend here that. If this was all I was using, I might have to spend a little bit longer here, but it's an adjunct. It's just something I add in at the end if I'm not getting the desired results that I want. So I add it in. Particularly, it's fantastic around bones, bony area and joints. So again here, where it's actually, unless you're using dry needling, around here it's actually really quite nice to get through that multitude of ligaments that are around the back.
Well, you talk about dry needling in your book quite a bit, and obviously you use that.
Yes.
At what point do you decide to use it? What's the evidence for it? How effective do you find it?
Yeah, there's beautiful evidence out there on, obviously, on acupuncture and pain, but there's also some great evidence, from Longavine when they're using the fascial winding. Yeah. And Gunn has done some stuff where it kind of is like almost like piston needling. So I find I use it when there's either somebody's really quite uncomfortable, and so hands-on techniques are too sore, so I can use them. Obviously, can't use them if somebody's scared, if they refuse to have them. So then we work around that, because I would never talk somebody into doing that. But equally, if something's incredibly stubborn. So if you've got something that you're working on and you're just feeling like you're literally flogging a dead horse, or you're going to put trauma into that tissue because you're working, you've got to kind of move away at some stage. Sometimes popping and needling.
Yeah. And are you working very specifically with your needles, or are you working globally with
Oh, no, it's dry needling. It's not acupuncture. It is.
No, but you might be using trigger points remote from the site of pain.
Yes. Yes, it's where the pain is. So if I might stick needles in the QL. It might be around erector spinae. It might be right around the joint. It's likely to be glute med, glute max kind of area, and sometimes into adductors to try and just get that freedom of movement. It's very specific. If I'm working on these tissues, and I'm finding that I can feel areas, and it's just getting irritated. I just don't want to spend too much time on there. I'll pop a needle in.
Yeah. This is a question which I think is really asking you to explain the straight leg test that you did a moment ago.
Sure.
Which we kind of distinguish between the straight leg raise test and the active straight leg raising test, which you did, because the question is, how can you do an accurate straight leg raise if you're using both hands to push inwards either side of the pelvis? As this viewer understands it, the operator should be taking the weight of the leg, as in an SLR, as opposed to an active SLR.
Oh yeah, it's active.
Doing. Yeah, could you just explain the difference between those two tests for us?
Sure. Can you pop onto your back for me, please? So a straight leg raise test, or a straight leg raise test, which also has one of the best sensitivity and specificity for neurological, it's very passive. Okay, so I'm doing the work. Okay, so your leg is completely relaxed. I'm taking the leg up into a position of when you feel a bind. I get the patient, I can pull the toe up, and then I could just get you to lift your head up. You've got no problems in your back, have you, before we do this?
No, I'm fine.
Yeah, okay. And then we would be looking for a pain distribution down the leg. So this is a passive activity. The reason the other one is active is because we want to see how the load is transferred in supine. So in this position, it's kind of like getting them to stand and lift the leg. You know, is there load transfer, or are they all over the place? Is it very, very hard? This is just another way of looking at load transfer. But so they have to do it themselves. Has that answered the question?
I think it has, yes, and we'll certainly make that clear in the text summary, about the difference between those two tests. An observation from one of our viewers here about your little tool there. Apparently this person has a fab tool called the Fascial Edge, supplied by a chiro called Andrew Glazier.
I've heard of Fascial Edge, yeah.
And has been using it on horses for
Fabulous.
for 8 years, and in clinic, and apparently it saves their fingers a lot of work.
Yeah, it does.
So the hoof pick does come in handy.
Yeah, I don't ever get. I've been doing this for forever and a day, and I don't get any hand pain or hand discomfort. I use my hands all the time. For me, this isn't my be all and end all, but it does have a place. And I saying to you before, I kind of like, it's like, oh, something that does what I used to do, but it does have quite a significant impact on some structures, and it's like I say, particularly around joints where you can just suddenly get freedom into. It's just very, very nice.
Could you, we talked about, again, this a little bit earlier on, and I wonder if we can actually do this on the treatment table where the cameras can see it properly. Could you talk us through the process of getting a non-athlete patient, let's say an ordinary person, into the plank position? How would you get them to do that, given that they've probably got a painful SI?
Yeah, okay.
And then how do you assess whether it's a good plank, a bad plank, or whatever else, given that they're not athletes and can't hold it for 3 minutes?
I'm not looking for them hold it. 30 seconds is good for me. So so if you just pop onto your can you do a plank first?
I believe so.
Yes, right. So that's the first thing I would ask. And if they couldn't get into an all fours position, that's how I would start. So can you just get into all fours, please?
Facing this way?
Doesn't matter which way you go. And again, you'd have to have a nice couch that isn't wobbly, or you'd have a quite often I take them out onto a mat in the gym and just use that way. So in this position here, you'd want to know whether they could hold that position, and if they were quite comfortable in this position, then you'd ask them to take their knees a little bit further away, and then just try a plank like that. So keeping your bottom nice and straight, just go. Can you go down onto your elbows for me? Because it's a little bit easier to hold that and drop that bottom a little bit if you can.
So we're looking for a straight line along the thighs and the upper back.
It needs to be completely straight, So drop that down a little bit more. Lovely. Okay, and is there any pain there? If not, can we go up onto your feet? Lovely. So he's really good at that. Okay, head needs to be in complete neutral. Elbows ideally want to be directly under your shoulder, otherwise it's quite hard to hold. It's quite hard to hold, and you're actually gripping to hold yourself the position, and you need to be in a perfect straight line in that position there. And if they can't hold it for a period of time, then you would just build it up. 5 seconds.
the period of time is irrelevant. You're just trying to increase the amount of time they can do that. And
irrelevant.
this is something you can send them away to do at home.
Yes.
Would you make them do this in front of a mirror so that they can check that they're holding the position correctly?
Yes,
or?
yeah. Usually, quite often what it is, I'm demonstrating, I'll demonstrate it. They've got a pic, I'll send them, I use a program called Rehab My Patient, and on there are videos. Shows you exactly how to get into the position.
Right.
So it's not just a picture. So I use that program regularly, and obviously I demonstrate it. They try it, and they'll quite often go, can you just check me again?
Yeah.
And it's usually where the bottom is the problem.
Okay. A question from my technical team. Can we do another demonstration? Have we got a camera that can observe the thigh thrust technique? We've got a wire problem on a camera? No? Right. I've been asked if you could demonstrate the thigh thrust technique.
Sure.
Sorry, I didn't want to
Pop
do
onto
this
back
if
for
we
me.
can't get this broadcast. So.
No, it's fine. Can I just get rid of this tool? You hold that for me, please.
That's a weapon.
It's a weapon. Lie down for me, please.
It's probably a weapon you can legally carry in public without getting arrested.
Look at that.
So I work on a bed a lot lower than this because I like to be able to just bend your knee for me, please. Okay, this doesn't hurt unless it's painful. So basically what you're doing here, might have to climb on. It's a bit high. I'll fundamentally try it. So basically what you're doing here is you're going to get the femur directly above the acetabulum, and then all you're doing is you're pushing down with a force. That's all it is. It's a thrust. And it's a quick one because you don't want to be holding the position for too long if it's painful, and it should just, yes, I can feel that. That's painful. Like, straight away you're always looking at their face, looking to see what their reaction is.
So on its own, that's not in itself diagnostic, but
No.
it's one of the 4 tests. And
Yes.
So the first one was distraction.
So yeah, thigh thrust is
Distraction.
got the highest sensitivity, and distraction is got the highest specificity. Okay, so distraction again, one hand on each ilia. You can cross your hands over, or you can do it this way, whatever you like. And again, all you're doing now is not, you don't want to be holding it too long, but what you want to do now is push the ilia out and towards each other at the back. Okay, so you're basically pinching the SIJ. So you're pushing away from the midline, and then that would cause pain.
And we're looking for pain in the same
Pain.
site as
Pain.
it came up at.
Yes.
Compression is the opposite, presumably. Or would you do your compression sideline?
I do compression sideline, so you can do it like this if you're really, really strong. But I like to, if you sideline for me, please. Because this way you're getting the best of both worlds. You're already compressing on this side.
Yes.
Bend both knees for me, please. Okay. Climb up on the plinth. And again, put your hand on top of the ilia and just push down. But don't, and again, so this time you're gapping the SIJ and you will get pain.
Okay. 4 tests. So we've got.
Yeah, so, and then the last one is the sacral thrust. Sorry, pop onto your tummy. So the first 2 are imperative. You do those first. Then if you've still got a negative, or if you have a positive, like they say, and they like to do a cluster of 3, hand, heel of your hand, straight down onto the sacrum, straight into the middle, and a thrust. Okay? Looks a bit like a cavitation, but actually what it is, again,
Are we talking high velocity thrust or a nice gentle thrust like you just demonstrated?
Yeah, it's
there?
a gentle thrust.
Yeah, so
because you're not
load it slowly.
The idea is not to manip. The idea is to just drop in and see if there's any pain. Okay?
Yeah. And Jace from Norwich is hogging the airways.
Jace, you're back. Hi.
Can we see a reverse plank, please?
Reverse plank, yes. Go on to your back. Do you know what a reverse plank is? Elbows behind you.
I don't know.
Yeah, so bring your elbows behind you in this position. Put your legs out straight, heels on the ground. Lift your midline up. Reverse plank.
Now, what
Head
about?
straight.
Yeah, I was going to say keep your neck
Head
straight.
in neutral.
Yeah.
Just, that's it.
What are we getting from this one? What's it doing for our patient?
Well, there's 2 ways of looking at this. Just
You can
relax
relax
now
now.
for me. Thank you. This is actually one of the bunkie tests. So this is a posterior power line. This is exactly the position you get into.
Yeah.
And what you're looking at here is those structures in that superficial back line. So all of the erector spinae, down into the glutes, into the hamstrings, calves, they're all active in this position. So you're looking for how long somebody can hold it again. Are they stable? Are they wobbling all over the place? Is it possible for them to do it?
Yeah. Okay.
Are they feeling any pain doing it?
I wanted to go through some of the other adjunctive therapies that can go on with this. You talked about prolotherapy and injections earlier on. Now, at what stage do they come into our diagnostic or therapeutic process? Are they a good diagnostic tool for a start for sacroiliac pain?
I think that the ones that seem to be good doing is somebody that's just using local anaesthetic to see if the local anaesthetic deals with the problem.
Yeah.
And if it does, then it's worth pursuing to see if there's anything else, whether that be a steroid, whether that's prolotherapy, whatever the doctor. It's not my field, I don't do injections. So, you know, I can't necessarily go into great detail about this, but from my experience, that tends to be what happens. They'll do a kind of like you say, a diagnostic, local anaesthetic trial.
Yes.
And if that's effective, then they will go through doing prolotherapy or...
And there's been a lot of controversy about injections of this nature, hasn't there? Because unless they're radiologically guided or ultrasound guided, then there's a huge possibility of them giving false results.
Yeah.
And how many places can you expect will be able to do that quality of injection? GPs generally can't,
No,
can they?
in my experience, it's done by a sports doctor, and it's under guided ultrasound.
Yeah.
It always has been. They are very, very specific, and so yeah, if your GP offers to do it, I'm not sure I would be 100% behind that. You know, I would be unless they've got a specific diagnostic centre.
Yeah, and whatever results you get from that could easily be wrong, because if it's not guided, you don't know that your anaesthetic or your anti-inflammatory has gone into the right place.
Again, you would hope that with the subjective information that you're getting, what the person feels, how they feel it, when they feel it, combined with the tests that you do, combined with the treatment that you do, it's very, very rare that I have to refer somebody to go and get prolotherapy, because you would hope, in most cases, that what you're dealing with, and you're dealing with dysfunction and lack of movement and shortness and weakness and inhibition. Once you've dealt with those things, 9 times out of 10, 9.5 times out of 10, they're better.
We haven't actually discussed what prolotherapy is as opposed to anaesthetic or steroid injection.
Right. So it's a sclerosing agent. So they inject this sclerosing agent that kind of thickens the tendons and the ligaments around the joint to stop movement. It's almost like a type of fusion in a way, but injection guided. In my experience, it's happened with people that have particularly loose SIJs. They could be hypermobile. Again, they could have pelvic inflammatory problems. It could be post having a baby and all of these kind of problems. And so the ligaments are just not responding to additional load and proprioception, which theoretically should kind of start to offer more support. So they put a sclerosing agent in.
Has it got a good track record?
It's got a variable track record, I think I would say. I think that there's some people that respond incredibly well to it, and there's other people that don't.
Okay. Where is it done, though? I mean, it's not common, is it?
It's pretty common in my experience.
Really?
It has, I know quite a few people that have had it done, and I know people that have come to me after they've had it done. I've only had one personal experience where I've sent somebody to a sports doctor to discuss the possibility of that, and that was a hypermobile person.
It's interesting, because I was under the impression that prolotherapy had actually fallen out of favour in the medical community for a long period of time, but it has kind of resurfaced again as being a...
Well, maybe they're using it in different ways.
Yeah.
I mean, again, the research changes, doesn't it? It's up and down. Yeah. Somebody will say, because there's been, there was a lot of people using Traumeel and PRP, and and it's like, it goes through flavours, I think.
I'm not going to tell you who asked this question.
Jace.
How would you teach diaphragmatic breathing?
Okay, that's a really good question. I'd always start with them on their back, because that's the easiest way to get it to go. It's quite hard to do it sitting up, and it's quite hard to do it standing. So once they've nailed it on their back, then they can kind of practice it. So I always get them to put one hand on their chest and one hand just below their ribs. And I always say, first time I just say, try and take a deep breath without moving your chest. Really hard for people to do. Then I say, try and take a deep breath, sticking your stomach out, because that's not ideally what you want, but that's kind of what you're trying to say to them. So I say, take a deep breath and stick your stomach out. And then after a couple of times, they kind of go, oh, I get it now. So once they've gotten used to the movement that should be happening down here by just pushing their tummy out, they can actually breathe into that space.
Right.
So that's how I normally get them to do it.
And are you going to give them exercises to make sure they're doing that at home? You know, the same thing, hand on stomach, hand on chest?
Yes.
Or are you just going to trust them, having done a couple in the clinic, to go away and do it properly from
No, I tend to, again, I think, you know, I look at psoas activation, and you can tell when somebody's doing it, usually, and if they're doing it right, because it does change the strength of the psoas quite quickly. And usually once they've seen that, they've bought in. Right. And they're doing it, and they go, I was doing the breathing, it makes me feel fun. And it is about, with a patient, they have to see results, they have to see what the benefit of them doing it is. People are notoriously bad at following, let's go do these exercises, or here's your exercise sheet, let's go do it. They're notoriously bad at that, but if you've shown them something's changed, you can all of a sudden, you can have, you've got buy-in. They're like, I can't believe the difference. And so then I don't really have trouble getting people to do that. I don't generally have problems.
You're actually backing up an awful lot of what Leon Chato said. I'm sure he'll be really pleased to hear that, won't he?
Good.
But he also talked, and it's worth looking back at that recording if you have the time, because he talked about pursed lip breathing as part of a training technique to avoid over-breathing, all of which will affect the muscles that we've been talking about so on already. I wanted to ask you about taping. Now, in your book, you talk about dynamic taping. Is that the same as K-taping?
No.
Right.
Dynamic taping is the bomb.
It's the what?
It's the bomb.
Right.
It's a fantastic tape. It is I love it. It's the only tape I use. I've used every other tape on the market and nothing comes close to it. It has it can stretch widthways, diagonally, lengthways.
Well, that's what K-tape does, isn't it?
No, it usually only goes lengthways. Okay. It doesn't have all of it kind of acts like fascia. It has the difference between K-tape, kinesio tape and dynamic tape is that dynamic tape it's trying to affect the eccentric load on the muscular tendinous unit. So what it does is it slows down that eccentric load. So you put it on in a shortened position. Most K-tapes are put on in lengthened position. So you put it on in a shortened position, and you can make it. You can do a power band, or you can use the black. They've got this new eco band, which is super thick, fantastic around Achilles and things like that. So basically, you put it on a shortened position. You smooth it down, and you put it on. But you have to have a really long anchor, because you can imagine if you're trying to control eccentric loads, it could actually pull on the skin, and you could actually have blistering. So it's really, really important that the very long anchor. And then what it does is it controls that eccentric load, and then what it does is it puts an elastic recoil back into the muscle, so it kind of protects it, but kind of enables the muscle, if you like. So you're able to continue training, continue competing, assuming it's not an injury.
You run courses on this?
Yes, I do, but I tend to put it all in one again. Okay. So if I'm doing a course on the SIJ, it's something that we do on the SIJ. I don't just do it as an individual course. However, dynamic tape do them, and they're very, very reasonable. So
I have to say, I mean, we've had a speaker in to talk about K-tape and the other varieties of that in the past. And I'm less convinced by the theory behind that than I am by what you've just described about dynamic tape. And I'm not saying for a second that K-tape doesn't work. No. It may just be that I don't completely understand why it doesn't work, or the mechanism isn't quite what was explained to me. Is it good for tennis elbow, dynamic tape? Says Tim from Hereford.
Yes.
Right.
So you would tape the arm in this position and this position. So again, the shortened position, because obviously you're talking about your lateral, your lateral epicondylgia. So you want to go into the hand, across the arm, okay? And then you also want to come down from the forearm. And so you're basically reducing that eccentric load and that eccentric load. Right. And then you can do a very similar...
Is it simply unloading the tissue, or is it helping to rehab those tissues as well?
It's both. It's unloading, but it's helping the eccentric load. It's reducing the eccentric load, which is where a lot of that kind of things happen. So it's quite hard to tape. Well, I guess if you're left-handed, it's quite hard to tape yourself. Certainly when you're doing your hand or your arm or anywhere else, but it's really easy to do I've taped myself with Achilles and plantar fascia, and it's had amazing results. Right. So I don't sell this tape. I've got no financial, but I love it. It's brilliant.
We have just a couple of minutes left. I said earlier on you had an effect on our audience. You've certainly had an effect on Jace from Norwich because he wants you back in apparently.
Jace, hi!
He wants you to come back and do some more
back.
because this is going down very well with the audience. There was a question about how you test SOAS, which I think we're going to have to leave, well, unless you can do it very quickly.
I can
and
describe
there are some
it.
standard. Yeah, go on.
Yeah, I can describe it if you like. I can show you it. It's up to you.
We haven't time to do that
Yes.
now, I'm afraid.
So very quick description. Person's lying in supine. Leg is extended. Take it up into about 50 degrees of flexion with the leg straight. Laterally rotate the leg. Hold that and get the person to hold that position. And if they can, and then say, don't let me push your leg down. You push your leg down, and usually it goes like that. Then you get them to do a few diaphragmatic breaths, and all of a sudden the strength is there, and they're like, what?
Right.
So it's a really nice test. Obviously, the other one would be standing, and you'd have to go above 90 degrees to get SOAS. Otherwise, you'd be influencing.
And my final question is about sacroiliac belts.
Yes.
We haven't talked about piriformis, have we?
No, but that's okay. It's fairly.
Jace wants you back in. We'll talk about piriformis.
Come back.
Are they good? Are they worth having?
I only use one, and that's the Sorolla. I think they're very, very good if you need one. I have one because I have SIJ problems myself, and it can get me through a day. You know, and the good thing about an SIJ belt for me personally is that it's not like wearing a corset where everything just goes weak. What it is a massive proprioceptive afferent input, and it kind of wakes things up for me. So I can wear it in the morning, and then I can take it off, and I'm fine.
We haven't had time to cover some of the other research about those, but I do remember reading that with the sacroiliac belt, it had to go above the trochanters, and the force required to make it effective was about 50 newtons, which is described as being the same force you use to tie your shoelaces. So it's not huge force, is it?
No.
But it's just a little bit of stabilising compression on the joint.
Yeah, exactly that. And it does feel like it's squeezing you. And you can use dynamic tape to do that as well, but the SIJ belt itself is really, really quite nice.
Okay. A question about what taping would you use for the SIJ? I'm assuming you use dynamic tape, as you've just said, in the same sort of manner.
Yeah. So you can go round the thing and then you can go all the way around across the joint and go down. And also it's very, very nice to tape the oblique line going from your lats down into your glutes as well to kind of give that a wake up.
Paula, I'm hurrying you now, I'm afraid, because I can see the clock.
Okay.
You run your own courses in all the stuff we've been talking about this evening. There's a lot that goes beyond basic training there, and you run master classes for experienced physiotherapists. So we're not talking about newbies here, are we? Where do you run the courses?
Most of the time they're in Birmingham because that's closest to me, and there's a nice place there. But you can find all that information on my website. And
we will put a link to your website up very shortly. The book that we've been referring to is this one, which there will be a link to as well on the website, which is Sacroiliac Dysfunction and Piriformis Syndrome. Very comprehensive in dealing with all the therapies that we've looked at, including our hoof pick tool earlier on. Hopefully we'll get some people come through on those courses for you, because there's clearly a lot more in this. It's not just the sacroiliac, it's all this holistic stuff that we like to think about. We've had some really good feedback to tonight's discussion, and thank you for all the questions, particularly Jason Norwich. That was very helpful. We'd like to get some more of that next time. Our next one is our 4th visit by Tim Watson, talking about electrotherapy. This time we're going to be talking about the weird and the wonderful, the stuff that practitioners and patients can buy on the internet. Do they work or don't they work? So it should be quite entertaining. Well, it's always entertaining with Tim, as those of you who've seen him before will know. One final update. We have places left on Stephen Sandler's course next month in November. There is no longer a requirement to do the one-day preparatory training if you don't have functional training already. It's going to take anybody from any stage of learning, whether they're just out of college or whether they're experienced osteopaths, to teach them how to deal with cardiothoracic problems, so anything above the diaphragm. So this fits in really, really nicely with what Paula's been saying today and with what Leon was saying before, and we'll give you treatment protocols which you can use in clinic on the Monday after the course finishes. Well worth looking at, well worth attending, and Stephen Sandler, as most of you will know, is a superb practitioner himself. That's all we've got time for this evening. Paula, thanks very much. That was great fun and a huge amount of information. Hope you enjoyed it, and I hope we see you again next time. Thank you.